Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing erectile dysfunction. The reason we're discussing this topic today is because erectile dysfunction affects many male patients, particularly those of older age. And when a patient develops erectile dysfunction, it can affect not only their love lives and sexual well-being, but it can affect their overall mentality and overall well-being as well. So our learning objectives are here today. So we're going to explain anatomy and physiology of male sexual function and performance. We'll talk a little bit about erection and physiological effects of erection. We'll discuss types of erectile dysfunction. We're going to talk and describe the causes of diminished sexual interest and activity, including most common causes of ED, particularly how medications and medical conditions can affect libido and sexual activity and ED, and how testosterone also has an effect there. We're going to talk about medications and non-pharmacological recommendations regarding ED, including mechanisms of action, adverse reactions and drug interactions, contraindications for different ED products. And we're also going to recommend appropriate interventions for treatment of ED for patients' specific situations. For exam purposes, we probably will be focusing on these last four objectives, starting with describe the types of erectile dysfunction and recommend appropriate interventions for the treatment of ED for specific patients. So basically the last four are the ones that we will focus on mostly for testing purposes, just an FYI. We're going to start off with a simple case. BD is a 45 single Caucasian male who presents to the primary care clinic with concerns that he's not been able to perform the way he used to when he was younger. He's been dating his current partner for 3 months. Stacy has no problems with his libido, but cannot become erect for sexual activity when the time is right. He has no noted past medical history, and his vital signs are stable in the clinic. So question 1, which of the following should be collected or ascertained when interviewing BD regarding cause of his erectile dysfunction? Alcohol usage, current medications, smoking history, or all of the above? Question 2. Assuming a cause of erectile dysfunction cannot be identified and corrected, and BD is currently taking no home medications, which of the following is most appropriate to treat BD's erectile dysfunction? Intracavernosal prostadil, oral sildenafil, penile prosthesis, or vacuum erection device? And then question 3, what is an adverse effect of the agent or device or non-pharmacological agent selected in question 2? Cavernosal plaque, hypotension, infection, or weight gain? So after we have this discussion today about erectile dysfunction, you should be able to answer all of these questions confidently. So a little bit of epidemiology and background about erectile dysfunction. Erectile dysfunction increases as men age, and the incidence is low in men who are younger than 40, but increases in men who are 40 and above. There's about a 52% incidence reported in some studies in men who are 40 to 70 years old, and once men hit 70 years old, there's as high as an 80% incidence in erectile dysfunction. So this is a very, very important thing, especially if a male is sexually active. They may experience this at some time during their lives, particularly as they age. A little bit of background about the anatomy and physiology of the penis. So the penis is actually made up of multiple parts. We have 2 corpora cavernosa on the dorsal side, which are basically these large areas, circular areas that you see here in the middle. We have 1 corpus spongiosum on the ventral side, which is this bottom portion here. Now, keep in mind that as males are normally functioning and their penises are flaccid or essentially flat, arterial and venous blood flow into and out of the penis are regularly normal. However, when a male gets sexually stimulated and becomes erect, the corpora areas, so the corpora cavernosum and the corpora spongiosum, fill with arterial blood, and this causes the penis to elongate and swell. And that is essentially what happens during an erection. Also, during an erection, the venous outflow of blood is decreased from this area, and that basically causes the erection to be prolonged for longer than a few seconds to a few minutes. So during this process, arterial blood flows in, venous outflow is minimized. Now, whenever a penis becomes erect and the male is having sexual activity, ideally one of the goals in a lot of different sexual activity, particularly penetrative intercourse, is ejaculation. And what ejaculation is just propulsion of semen as a result of a climax or an orgasm. And there are different stages to ejaculation. The first stage is contraction of the reproductive ducts and accessory glands, emptying contents into the urethra. Constriction of the bladder sphincter muscle, which prevents urination so that urine doesn't go through the penile shaft or the urethra as the male is getting ready to ejaculate. In addition, penile muscle contraction and propulsion of semen. Usually this part is where the male orgasms and they experience intense pleasure. But also during this time, patients may also experience tachycardia as well as elevated blood pressure. So sexual activity in patients who have, say maybe a cardiac history like hypertension and heart failure, for example, could potentially be cautioned against depending on how elevated that blood pressure gets. In most normal patients, it's not to the level where we would be clinically concerned about it, but in a patient who maybe has a cardiac history, we'd be a little more concerned. Now, post-ejaculation, the penis becomes flaccid again through the release of norepinephrine and accompanying vasoconstriction. Remember, during the erection, vasodilation was occurring, which allowed for the blood to flow into the arterial areas of the penis, allowing for the erection to occur. Now, post-ejaculation, that blood essentially is kind of returning to a normal state, and there's less blood there. And then post-ejaculation, there's also a latency period in which another orgasm cannot be achieved. And this latency period is not really defined well time-wise. It really just depends on the patient. Some other factors that we need to consider whenever we consider erection, as well as ejaculation and erectile dysfunction in general, is that when a patient develops an erection, a lot of the dilation is actually acetylcholine mediated, and this is done through nitric oxide production. Remember, nitric oxide is a vasodilator, and this vasodilation will increase arterial blood flow into the corporal areas of the penis. There are also other transmitters that help with the vasodilatory effects, such as cGMP, CAMP, CAMP, vasoactive intestinal polypeptide, and prostaglandin E. And these are important just to know about and be aware of, because a lot of these can actually be targets that we can use in terms of ED therapy, particularly prostaglandin. Another thing that we have to consider whenever a patient is becoming erect is that they have to have the appropriate psychogenic stimuli present. So they have to basically be aroused. And if they have some kind of problem in becoming aroused, say whether it's because of a medication, a disease state, or, even the relationship that they're currently in, because sometimes, a patient may, have sexual activity with someone who they might not actually be, stimulated by. In those cases, psychogenic stimuli play a role in the erection. And then the eventual sexual activity of that patient. Also, hormonal systems play a role here too, particularly with the male. Testosterone plays a role, and that is another target of drug therapy that we may be particularly concerned about with erectile dysfunction. If testosterone levels are low and libido of the patient is low, we might target that pathway through giving testosterone replacement. So in terms of etiology of erectile dysfunction, we've talked about a little bit or alluded to some of these already, but etiology of erectile dysfunction is divided into two different sets: organic erectile dysfunction, which is about 80% of patients, and psychogenic erectile dysfunction, which is about 20% of patients. For organic erectile dysfunction, we are focused mainly on the vascular, neurologic, and hormonal etiologies of erectile dysfunction. So things in terms of vascular and peripheral vascular disease where blood can't flow properly, arterial sclerosis, again, where blood cannot flow properly, and hypertension, again, where blood cannot flow properly. Blood can't flow properly into the penis will have a harder time becoming erect, particularly if these disease states are not well controlled. Just because a patient, though, has, a disease state such as hypertension, for example, doesn't necessarily mean that a patient will have erectile dysfunction. If these disease states are well controlled, a patient can actually live a very fulfilling sexual life. Additionally, things such as neurologic factors play a role. So if a patient has stroke, spinal cord injury, or very uncontrolled diabetes, for example, neuronal transmission to the penis to become erect will not be adequate. And when these patients, if they have enough damage neurologically, they may not be able to perform in the bedroom as they would like. And then, as we alluded to earlier, hormonal causes of erectile dysfunction, such that where you get hypogonadism. And in some patients with certain types of hypogonadism, particularly testosterone deficiency, this can be again mediated by testosterone, assuming that their testosterone level is low and they have decreased libido. In the other 20% of patients, we actually have psychogenic erectile dysfunction. And essentially what psychogenic erectile dysfunction is they don't have the psychogenic stimuli to develop an erection. So a patient may have some type of psych disorder or other mental health disorder. They may be sedated. They may be just reactively depressed, such where you might actually have depression maybe from a substance such as alcohol. Or the patient may just have performance anxiety whenever the time comes to become sexually intimate with their partner. It's important that we also factor in the psychogenic causes of erectile dysfunction, because sometimes, obviously, disease states can play a role with this, but also medications may also have a role in causing psychogenic erectile dysfunction. And that is very important to note, because if you can correct the psychogenic cause or minimize the psychogenic cause, you can get the patient performing how they would like again. So, as I alluded to, social habits play a big-time etiology in erectile dysfunction, particularly alcohol usage. If a patient uses alcohol, they are more likely to not have an erection, particularly with large, copious amounts of alcohol. So say if they are drinking prior to intercourse, it may be harder for the patient to actually develop an erection. Now, in terms of smoking history, smoking actually causes vasoconstriction. And remember, in the terms of the physiology of the penis and the physiology of erection, we want vasodilation in the arterial system so that we are able to get blood there. And smoking will essentially blunt that effect by the mechanism of vasoconstriction. Medications play a big role in causing or being a potential cause of erectile dysfunction. So some medications that are common in causing erectile dysfunction, and this list is not all inclusive, but includes a lot of the classes that may contribute to the endpoint of not having an erection. Those include anticholinergics, such as antihistamines like Benadryl or diphenhydramine, TCAs, or tricyclic antidepressants like amitriptyline, nortriptyline, doxepin can cause erectile dysfunction or lead to erectile dysfunction. SSRIs and SNRIs, particularly the ones that are listed here, may have a role in contributing to the end point of erectile dysfunction or erection. And this is mainly more so due to the fact that these medications blunt orgasm effects. as well as the patient psychogenically. So if they are on one of these agents, it doesn't necessarily mean that they can't have an erection. It just means that for some patients, erectile or erection may be a little bit more difficult. Dopamine antagonists such as metoclopramide or Reglan, estrogens, and anti-androgenic agents such as spironolactone and ketoconazole. These are essentially more or less acting against testosterone. And remember, we said testosterone is a big component of why patients can develop an erection in the first place. CNS depressants, again, we mentioned alcohol already, but other CNS depressants are also included here. Benzodiazepines, lorazepam, diazepam, for example, barbiturates like phenobarbital, opioids, so your standard opioids, hydrocodone, oxymorphone, hydromorphone, etc., and anticonvulsants, particularly those that are sedating. You also are concerned about agents that decrease penile blood flow. So those are diuretics, and diuretics of any class, particularly those loop diuretics. Peripheral beta antagonists like carvedilol, and then our central sympatholytics such as clonidine, which is basically an alpha-2 agonist centrally. We also have miscellaneous drugs that can contribute to erectile dysfunction. So we have finasteride and dutasteride are 5-alpha reductase inhibitors that are used traditionally for BPH. Lithium, gemfibrozil, and interferon, which is used in many immunological disorders. In terms of diagnosis of erectile dysfunction has to happen over a longer period of time. So we need to really assess sexual activity over the last 1 to 6 months. A diagnosis can be made with assistance of a self-administered questionnaire such as the International Index of Erectile Dysfunction, also known as the IIEF. There are short versions of the IIEF, such as the IIEF-5, which are composed of a shorter amount of questions than the standard International Index of Erectile Dysfunction, which composes many different questions. So, for example, with the IIEF-5, it's only made up of 5 questions. Higher scores indicate normal function of the penis and erection. If you have a lower score on the IIEF-5 scale, you are more likely to have some kind of etiology of erectile dysfunction, with lower scores being more severe, as you see here. These scores, I will not necessarily have you know like what is mild and what is severe, but I just want you to be aware on the IIEF-5 that the lowest score of 5 is bad or the worst, and the highest score of 25 is normal. This is what the IIEF-5 looks like. Again, it has 5 questions, and it's basically ranked on a Likert scale. The patient filled this out themselves. So it can ask questions such as, over the past 4 weeks, how would you rate your confidence in keeping an erection? When you have erections with sexual stimulation, how often were your erections hard enough for penetration? During sexual intercourse, how often were you able to maintain your erection after you penetrated or entered your partner? During sexual intercourse, how difficult was it for you to maintain your erection to the completion of intercourse? And when you attempted sexual intercourse, how often was it satisfactory for you? All of these questions basically are answered with the Likert scale of 1 to 5, and then you basically add your score up from the 5 questions to generate your degree of erectile dysfunction, if you have a degree of erectile dysfunction. And whenever we're determining treatment, it's not necessarily a direct score that determines whether or not we're going to start a drug or a non-pharmacological recommendation for the patient. That's more patient-specific. But if the patient has a score of 22 to 25, it's most or more likely than not that we're not going to start a medication, because those indicate that the patient does not have erectile dysfunction. So our treatment goals in regards to erectile dysfunction are to improve quality and quantity of erection suitable for intercourse, and the satisfactory performance as perceived by both the patient and their partner. And that "and partner" part is very important, because Even though the patient may be satisfied, their partner may not be, and this can lead to problems down the road in terms of relationships. So we have many different treatment options available for erectile dysfunction. We have both pharmacologic interventions that you see here, the phosphodiesterase 5 inhibitors or the PDE5 inhibitors, testosterone replacement, prostaglandins such as alprostadil, yohimbine, papaverine, and phentolamine. And then we have non-pharmacologic devices, including vacuum erection devices or VEDs and penile prosthesis. So the one thing I want you to focus on during this presentation is this schematic from DePiro, your textbook. And this will essentially tell you how you go about treating patients. Now, it is obviously not all-encompassing of all of the agents that we just mentioned in the previous slide. But it does cover most of the pharmacologic and non-pharmacologic agents that we have there. And we will discuss the exceptions as well to this schematic. But for your testing purposes, I would highly recommend hint, hint, star, star to know this schematic. The first thing that you want to do in the treatment of patients with erectile dysfunction is you want to treat any underlying diseases or any other cause of the erectile dysfunction that you can identify. If we can avoid using a pharmacologic or non-pharmacologic therapy directly to treat a patient, such that you see in the lower half of the schematic, we're going to minimize that. So we want to treat any underlying diseases. So, for example, hypertension, if their hypertension is very uncontrolled, diabetes, peripheral vascular disease, etc., or even the psychogenic related disease states or the mental health disorders that they may have, like performance anxiety, for example. We want to discontinue any medications that can contribute. So it's very important to be aware of those medications that can contribute to erectile dysfunction that we mentioned. Remove all risk factors if possible. Now, sometimes it may not be possible to remove the risk factor, for example, peripheral vascular disease. If you have peripheral vascular disease, it's there. You can treat it, but you can't necessarily reverse it completely. So you must keep in mind that you need to treat the underlying cause, but if you can't fully treat the underlying cause, then you may need to jump to drug therapy or non-pharmacologic therapy. Now, if your patient has hypogonadism, you need to give testosterone replacement. And we will discuss that a little bit more whenever we actually talk about testosterone. The general first-line treatment for erectile dysfunction, though, is phosphodiesterase inhibitors, or the PDE5 inhibitors. So those include sildenafil or Viagra, tadalafil or Cialis, vardenafil, also known as Levitra or Staxin, depending on which formulation you have. Staxin is the ODT formulation, and Avanafil or Stendra. The reason why the ones that are bolded here are bolded is because these are the ones that are most commonly seen in clinical practice, and those are going to be the ones for testing purposes that I'm going to expect you to know. Now, obviously, I want you to still know that Avanafil is used for erectile dysfunction, but you don't need to necessarily know its brand name of Stendra. And I'll be honest, I haven't actually seen this actual drug in practice, but it does exist. The PDE5 inhibitors are competitive reversible inhibitors of phosphodiesterase isoenzyme 5, and these are found, this isoenzyme is found in the genital tissue. These agents are effective for about 60 to 70% of patients overall. Adverse effects of this class in general include headache, facial flushing, dyspepsia, nasal congestion, dizziness, hypotension, and priapism, which is essentially a prolonged erection, although that is very rare. An important point to make here, hint, hint, star, star, is that a contraindication to phosphodiesterase 5 inhibitors is organic nitrates. So things such as nitroglycerin, nitroprusside, and also isosorbide formulations that can be taken for angina or heart failure, like isosorbide mononitrate and isosorbide dinitrate. If you do have a patient who is administered a PDE5 inhibitor or takes a PDE5 inhibitor, it's very important that we hold those nitrates for at least 24 hours after giving the PDE5 inhibitor. And the exception for this is tadalafil or Cialis. We need to wait at least 48 hours after we give tadalafil. And the reason why we hold nitrates for these patients is because of risk of hypotension concomitantly, because as you see, these agents are antihypertensive agents. And PDE5 inhibitors can cause hypotension, which can be potentially deadly for a patient and require a hospital admission. In regards to the comparison of all these different agents, the bolded information is the information that I want you to focus on. So I want you to focus on the starting doses. Usually it is advised to start low or on the lower end of the dosing range and go slow with these agents because obviously of the risk of side effects, particularly hypotension. So with Viagra or sildenafil, the starting dose is 25 to 50. For tadalafil, it's 5 to 10. And for vardenafil or Levitra, it is 10 milligrams typically. Though you could also go and start with 5 with vardenafil as well, and that's not included on this slide, but that would be perfectly acceptable. You see the doses ranges here. Typically for most of these agents, you're going to probably take them between 30 minutes and 1 hour prior to intercourse. The duration of therapy of these agents ranges, and it's very important to note here. For sildenafil and vardenafil, they last about 2 to 5 hours or 2 to 4 hours, depending on which agent you have. But however, for tadalafil, it can actually last up to 36 hours. Now, that doesn't necessarily mean that the patient has an erection for 36 hours. I want to be very clear about that. It doesn't mean that the patient is erect that whole period of time. It means that they have the capability of becoming erect during that time. So for Cialis, for example, Cialis might be a good agent if the patient just wants to take one tablet. And something I did not include in the slides is that you want to also consider cost with these medications. A lot of these medications are not covered by insurance for the purpose of erectile dysfunction, and as a result of that are very expensive, with some agents, costing as much as $50 to $80 a tablet. Cialis and Viagra, I believe, now cost in the ballpark probably of $20 to $30 a tablet. So with Cialis specifically, because it can work up to 36 hours, it may be beneficial for patients who are maybe going like on a weekend trip, for example, and they only want to take one tablet if they plan on having intercourse. In that case, they might be able to potentially develop multiple erections with just one tablet. It's also important to be aware about whether to take food with these medications. With Cialis, it's not necessary. With sildenafil and vardenafil, however, these should be taken on an empty stomach to promote absorption and overall action of the medication. So now that we've talked about the phosphodiesterase inhibitors, if those don't work, or if the patient prefers, or if the PDE5 is contraindicated, then you would potentially go to a vacuum erection device. A vacuum erection device is a non-invasive mechanical device, so it's essentially external. It doesn't go necessarily into the patient. It is a one-time purchase and can be used multiple times, and it contains two parts, a pump and a cylinder. The pump is the part that generates the negative vacuum pressure, and the cylinder is where the penis is inserted into one end, and the end of the cylinder is closed at the other end. The patient activates the pump to produce a vacuum pressure to draw arterial blood into the penis. And with that, erection can be prolonged by use of constriction bands or tension rings, which can be placed at the base of the penis or even drawn up the penis. The initial onset, the first time these devices are used, is typically between 3 to 20 minutes. However, as a patient gets used to the device and is able to operate the device properly and more efficiently, they can actually get an erection within about 2 to 3 minutes. A flaw of this is that these devices are not discrete. So obviously, if a patient decides to develop an erection with these devices, their partner will most likely be aware of it, because essentially the partner will probably be in the room with them as they're using this device. Therefore, these devices are said to work best in older patients who are married, or other patients of any age who are in stable relationships or are married, and in committed monogamous relationships. Obviously, some adverse effects of a vacuum erection device is that a patient can develop penile pain, bruising, or injury because the device may actually cause this. But however, contraindications to this include sickle cell disease and history of prolonged erections. With sickle cell disease, patients with sickle cell already have abnormally shaped hemoglobin, and because of that, blood flow may be altered in these patients. And the sickle cell patients in general are more at risk for developing priapism or prolonged erection. So if you use a vacuum erection device in these patients, it may be difficult to reverse the erection on its own, and the patient actually may have to go into the emergency room to get the erection reversed medically. This is what the device looks like and how to apply the device. So what can be done first with the device is you can actually apply lubricant to the device on the open end of the cylinder and the rim of the cylinder, as well as on the entire head of the penis. And this will actually help you to maintain the best erection. And you might also need to tell the patient to maybe possibly trim their pubic hair around the base of the penis to actually make an airtight seal. Now, when patients are using the vacuum erection device, it's recommended that the patient stand so that they can actually use the device. Place the lubricated penis inside the cylinder, and with one hand hold the cylinder at a downward 45-degree angle with the open end snugly against the body, because you want to create that airtight seal. And you may need to rotate the cylinder slightly back and forth to make an airtight seal against the body. And you do not want to draw the testicles into the device. It's very important. Once the penis is into the device, then you can actually activate the lever pump end, which is on the end here in this particular device. So it may be actually difficult for patients who may have certain disorders such as arthritis to actually use this specific type of pump. However, there are battery operated pumps that can do the vacuum process automatically. So it's important to be aware of those, and if you have any of those at your pharmacy, I would recommend those potentially over one of these pump devices that you have to actually hand pump for patients who have problems with manual dexterity. Now, if you've gone through the first few steps and you've gone through a phosphodiesterase inhibitor and or a vacuum erection device, if those are ineffective, you may need to actually titrate the dose of the phosphodiesterase inhibitor. Now, if that still is not effective, then you can actually use intracavernosal or intraurethral prostadil. And this is commercially available as Caverject or Edex as brand names or trade names. Prostadil in general is also known as prostaglandin E1. And if you remember prostaglandins earlier, they stimulate adenylate cyclase and CAMP production, leading to relaxation of the arterial blood vessels and tissues in the corpora. These are administered via intracavernosal or intraurethral route, approximately about 5 to 10 minutes before intercourse. Obviously, if you're injecting this intracavernosally or intraurethral with a needle or a device into your patient, it's going to be more invasive than the oral treatments. And because of this, we generally prescribe or recommend them after failure of a vacuum erection device or a phosphodiesterase 5 inhibitor. Now, if your patient has contraindications to both vacuum erection devices and phosphodiesterase 5, you could potentially start with this agent. Obviously, because you're injecting either into the urethra or into the cavernosal tissue of the penis, adverse effects can include hematoma, bruising, priapism, though the priapism with alprostadil typically happens at higher doses. Patients may also develop cavernosal plaques or fibrosis. If those develop, it's recommended usually to stop the alprostadil for a set period of time before restarting it again. Obviously, penile pain can result anytime that a needle is involved, and urethral pain through the intraurethral route can be present for these patients and may not necessarily be the most pleasant. This agent should be cautioned in patients who are obese, because obese patients may have a harder time seeing their penis below them to actually visibly inject properly the intracavernosal or the intraurethral alprostadil. Blind patients obviously would have the same problem. Patients with sickle cell disease, for the reasons we mentioned before, because this could potentially increase risk of priapism with those patients. Patients with psych disorders, the reason I would speculate it would be cautioned in these patients is probably because there is a needle involved, and in certain psych disorders, patients may have an increased risk of suicidal ideation, and a needle is not necessarily the best instrument to give patients with particular psych disorders, though if they have maybe like just standard anxiety or performance anxiety, or maybe depression related just to this type of situation, it may be okay. You have to evaluate every patient individually. Leukemia, multiple myeloma, usually these patients are at increased bleeding risk, and patients that are on anticoagulant or antiplatelet therapy, so warfarin, the 10A inhibitors, or even things as simple as aspirin or clopidogrel, Plavix, for example, may not necessarily predispose the patient to being the best candidate for alprostadil intracavernosally or through the urethra. This illustration from your textbook is a little bit blurry here with the actual top portion, but this just will show you how a patient can go about intracavernosally injecting alprostadil into the penis. And you see here it's basically injected into the cavernosal space here. What you need to do is you need to basically make sure that you appropriately counsel patients whenever they come into your pharmacy the first time that they are taking these agents, because this process can be a little bit scary. And this is the intraurethral method, also illustration from your textbook. If for this administration route, what happens is you'll insert it through the urethra down, and basically what will be actually deposited is an alprostadil pellet. In this case, in either case, whether you're giving intraurethral or intracavernosal alprostadil, you'll probably want to massage the penis for a few minutes after you actually administer this medication, or the patient administers this medication, to actually let the medication dissolve and get the full effect to become erect. Now, if intracavernosal or intraurethral alprostadil is not effective or is contraindicated, last line is usually to install a penile prosthetic agent. And penile prosthesis is invasive treatment of erectile dysfunction. It's usually reserved for non-responders to oral or injectable treatments. The placement requires anesthesia, and this is usually actually an outpatient procedure. The patient can easily develop an erection when the device is activated through essentially release of a fluid that is released from a pump. And this actually has the highest satisfaction rate of all ED treatments at 90%, which is pretty good. However, because this is an agent that you have to foreignly introduce to the body, obviously there's always going to be a risk of infection related to the fact that that prosthetic device is there, and also an erosion of rods through the penis. So if these little cylinders or rods that you see here on the right erode, that can actually lead to further anatomical problems in terms of even doing simple things such as urinating, and they will probably in those cases need to be removed. Erosion of the rods can also lead to infection as well. So this is actually an example of what one of the devices looks like. You see here, once it is surgically inserted, that you actually have an activation mechanism that is here that can be easily pressed, and that will activate a reservoir with fluid that will go in and inflate the prosthetic cylinders that you see here within the penis. So basically it is fluid that will cause the penis to become erect. You also have miscellaneous treatments for the treatment of erectile dysfunction. As we alluded to earlier, testosterone replacement is something that can be used. Yohimbe, which is an herbal medication, is usually not recommended because of lack of good evidence with erectile dysfunction. Papaverine and phentolamine are not FDA approved specifically for erectile dysfunction. However, they can be used off-label in a combination product called Trimix. And Trimix is a combination of alprostadil, papaverine, and phentolamine, which can be given intracavernosally. So while they're not FDA approved for erectile dysfunction, the combination of these agents can be actually given, and that combination has been approved for use, obviously, because of mostly the alprostadil component. Papaverine and phentolamine are not used as single agents traditionally for erectile dysfunction because the dosing that you would have to use would be so high that it would cause too many adverse effects. Now, going to testosterone and kind of flipping the script a little bit, testosterone comes obviously in many different formulations, as you're learning about in this course, oral, parenterally, buccally, or transdermally. The reason we use testosterone in erectile dysfunction is to correct symptoms of hypogonadism. So, those are things such as decreased libido, erectile dysfunction. Also, other things like small testes and reduced hair growth can be corrected by the administration of testosterone. And ideally, you want to get the testosterone level increased or restored to a normal level. And it's bolded here, the level 300 to 1100 nanograms per deciliter. And that is an important number that you'll need to know for testing purposes. Use in patients that have both decreased libido and low testosterone levels. So testosterone should only be used when a patient's serum testosterone level is low as well as decreased libido. It has to be both of these things. If they have a low serum testosterone level and their libido is okay, testosterone should not be used. If the patient's libido is fine, if their testosterone level is fine, but their libido is low or decreased, testosterone should not be given to patients with normal testosterone levels. It's important to screen for breast cancer, BPH, and prostate cancer before initiating a testosterone product. Adverse effects of testosterone products just in general include sodium retention, weight gain, and exacerbation of pre-existing hypertension, heart failure, and edema. Clots or venous thromboembolism may also occur with testosterone. Just a caution. A contraindication to testosterone includes prostate cancer as well as breast cancer. Testosterone agents in general should be cautioned in patients with history of substance abuse. And this is because a lot of these agents are actually controlled substance, many of them in controlled substance class 3. So, what happens if a patient develops priapism? Priapism is defined as a painful erection lasting more than an hour traditionally, but it's more commonly a longer process. It can occur in anywhere between 1 to 15 patients. Sometimes it may resolve on its own, but a lot of times it does not. And this is a medical emergency that requires a patient to be sent to the emergency department immediately. The treatment options for this are alpha agonist, and this basically allows venous blood drainage from the penis through more or less vasoconstriction. In terms of the agents that we can use intracavernosal phenylephrine as a first line. However, there is some data alluding to the use of oral midodrine for priapism, though I've never actually seen that in practice. I have seen intracavernosal phenylephrine be administered, though. So it's important to know that if you do have a patient develop priapism, refer them immediately, and they may actually receive intracavernosal phenylephrine. The way that this is given is typically around 100 to 200 micrograms of phenylephrine injected into the penis every few minutes. And this process is usually completed by a urologist, though other physicians can also do this process if they have the proper training. Here are the references for this talk. And back to our case of BD. So our Caucasian male, 45 years old, who was concerned about his sexual performance. He's been dating his current partner for 3 months, has no problems with libido, cannot become erect for sexual activity. He has no past medical history, and his vital signs are stable. So what should be ascertained when interviewing BD about his erectile dysfunction? The answer is all of the above. So we need to inquire about any alcohol use or any other risk factors, such as smoking as well as whatever his current medications are. Now, it does say he does have no past medical history, though even if you don't have any past medical history, the patient still may be taking medications, and we always need to check for that, because medications may actually be a reason why we have a patient with erectile dysfunction. Assuming a cause of erectile dysfunction cannot be identified and corrected, and BD is not taking any current home medications, which is the most appropriate to treat BD's erectile dysfunction? The answer to this question is oral sildenafil. If you remember from the schematic, PDE5 inhibitors and vacuum erection devices tend to be the first line. Particularly for vacuum erection devices, if the patient prefers to use a vacuum erection device versus taking a tablet. Otherwise, PDE5s are first line. And obviously, the first line is really just correcting the underlying cause. But we cannot identify one here in this situation. If PDE5 inhibitors or vacuum erection devices fail or are contraindicated, intracavernosal alprostadil or intraurethral alprostadil could be used. And if that fails or is contraindicated, penile prosthesis is usually the last line, and that's why those answers are not correct. So a PDE5 would be preferable in this case, and that is why sildenafil is the correct answer. The last question is, what is an adverse effect of the agent selected in question 2, which is sildenafil, and the answer here is hypotension. And as we discussed, this is particularly worsened in patients who are taking concomitant organic nitrates, and that is a contraindication to use. In addition, patients who have hypertension or on other antihypertensive medications in general, or taking antihypertensive medications that can cause hypotension should be cautioned against. It's not necessarily a contraindication. So say if they're taking an ACE inhibitor, for example, it's not necessarily a contraindication to taking a PDE5 inhibitor, but it should be watched out for. Cavernosal plaques typically happen as a result of injection of intracavernosal injectable agents such as alprostadil. Infection can happen as a result of the implantation of a penile prosthesis, and weight gain can happen as a result of testosterone administration. Those are why those answers are not correct in this case. The best answer here is hypotension. If you have any questions regarding erectile dysfunction, please let me know. Thank you and have a great day.